I usually pace when I'm talking, so I'm going to do my usual. I'm breaking the frame. I want to give you some statistics on the cost of caring. We talked a bit this morning about kind of what's going on. Us boomers, how many of you were boomers? Xers? Yers? Veterans? Some of you didn't raise your hand. Who are you? Us boomers, we heard this morning, are what, 12,000 a day? We are getting old. We provide the care to our parents, in-laws, loved ones, whoever. And I think it's quite interesting because in my practice, I've been doing this since 2002. I have had 4 men call me. Every other person that's called me has been a woman, okay? Women tend to take on that nurturing caregiver role. The 4 men that called me, they were either not spouses, wives, significant others. The woman in the family made the man make the call because he had to do something. So it's quite interesting. But I think it's important. The daughters do the personal care, but the sons provide the financial care, which is of equal importance. How many of you have had, and this sounds kind of bad, but how many of you have had to facilitate the transfer of a loved one from home to some type of care setting? Several of you. Hard? Maybe, maybe not, depending on where that person was cognitively. Why do we make those changes? Well, I think probably the first one is for safety. We talked this morning about, all we really can do is provide safety to the senior and peace of mind to the caregiver. Caregiver stress and fatigue. I'll walk into families' homes and whoever the caregiver, once they get to know me and feel comfortable with me, just start sobbing and telling me how hard this is and what they've been doing and how it's a loving kind of opportunity, but it's such hard work. The care needs expand. At lunch we were talking, maybe you have someone living in the home that's just making sure that there's companionship and transportation, but we age in place, right? So we get old wherever we live. The condo I live in, I moved in at 30 and everybody else was 60. I'm 60 and they're all 80 and 90. So we have aged in place and they're all widows now. So I'm the condo nurse and I take care of all the people that are in the building for me. We continue to change. Behaviors with dementia. If you look at the literature, there's lots of information out there about, should we treat people that have behaviors with dementia with drugs, and there are black box warnings. If you are, I have a family right now that the husband won't bathe, and he has a list of expletives for his wife that's unbelievable. When I'm in there, everything is just fine. But when I leave, he attacks, okay? And who do we attack? The person that is closest to us, the person that we feel most comfortable with. And so if you're working in a situation where somebody won't bathe or they won't eat or they're physically and verbally striking out at you, as a caregiver, it's even more difficult. Medication complication issues. Several of you have said family members were actually admitted to the hospital because of medication malfunctions. We know they're on lots of things. Caregivers are not available. So you live next door to your mom and your spouse gets a transfer or you get a transfer, and so there's nobody around anymore. So who's going to take on that responsibility? And those seniors can't live at home anymore if there's not somebody around. Family dynamics, okay? I'll take care of this, you take care of that, but you let your part down and it all falls to me and I just can't do it anymore. And the wishes of the senior. It is rare, but there are seniors that say, you know what, just can't do it anymore, it's too much for my kids. I need to make a choice about where I'm going to be. In my family, I offered to have my parents come live with me. They said, no, we love you, you have your own life, we don't want to be part of your life. And anyway, my mom and I would probably have killed each other. It wouldn't have taken very long. We love each other to death, but we probably could not have survived. So what I've done is I kind of call them pearls for success. There are some things, if you're looking at an institutional setting, to admit a loved one to. And when I'm saying institutional setting, I'm really talking about an assisted living or a nursing home, okay? We call them nursing facilities. So I'm looking at a place where care is delivered. The other least restrictive is an independent living, which is just a senior apartment building, and most of those buildings don't have any services available. Assisted livings or nursing homes, the prettiest does not provide the best care, okay? The one that's decorated in the most contemporary colors and in the newest stuff is not necessarily going to provide the best care, okay? I think, Anna, did you put in the checklist that I shared with you on how to look at a nursing home? Okay. If you're interested, talk to Anna and I'll share it with you, that I give to my clients to go out and actually look at a nursing home. How do you look at it? What questions do you ask? How do you critically look at it? And you know, coffee and cookies in the lobby, the receptionist that is really friendly is probably not it. So when you walk in that facility, what are you looking for that gives you an indication? Restaurant quality food, when I'm doing presentations to staff, I say, you know, used to be we had Charlie Trotters here, right? I don't know how many of you are aware of that. Gourmet quality food, does that mean McDonald's or does that mean Charlie Trotters? What is gourmet food? We're human. Everybody that's in your network of caregivers and friends are going to be able to do different things. You can't ask, or you can ask someone to help you, but if they decline and don't show up, you're not going to change their behavior. They are who they are. If that one sister is not capable of delivering, don't keep asking her for help because she's not going to deliver, and all it will do is frustrate you, okay? When my dad had a massive stroke, and so it was time to put Dad on hospice. I talked to my mom. We cried together. Talked to my sister. We cried together. I talked to my brother, and his response is, couldn't wait for Dad to die. Had to kick him off a little sooner by putting him on hospice, right? Didn't want to treat him. And I know what's going on. You know how that made me feel? It still makes me sad, all right? I'm not responsible for my brother's behavior, but what he said to me hurt my soul, right? I still love him. We still have a good relationship, but it has colored my attitude toward him, right? So when we're in these stressful situations, it's really hard to know how we're going to react and respond. And when we're under an emotional stress, we're not at our best, are we? Okay? We just really are not at our best. People don't change because you want them to. I want you to help me. If you're not capable of helping me, it doesn't matter how much I want it, does it? You're just not going to be able to help me. And so I can't count on you, so I have to find other resources that can help me. And we can only deliver what we can deliver, okay? We can't do more than what we're psychologically capable of doing. So we're looking at living at home or living in a facility where there are extra services. Now, on the assisted living side, at least here in Illinois, I'll give you an example. Most of the assisted livings are privately held. There are a few that are mom and pop kind of shops that have maybe one or two facilities. Assisted living facilities, most states they're regulated in the state. Nursing homes we'll talk more, but they're highly regulated. But assisted living facilities are less regulated. And a perception in our society is that nursing homes are not a place that any of us want to go. How many of you want to end your life in a nursing home? Raise your hand. None of you, right? Oh, do you? Good. In the one I own, right? And so what happens in assisted livings is the facility owner makes the choice about how sick people can be to be admitted and how sick they can get before they're discharged, okay? And if you're publicly owned and traded on the New York Stock Exchange, empty beds mean less revenues, right? So a full bed is a very positive thing. And so what I see in these assisted livings is they they admit residents that are too sick, and we call them residents, we don't call them patients, because this is where they live. They admit people that are sicker than what they ought to be, that what they can take care of, and they keep them longer than they ought to. They should be moved to a nursing home, okay? I have people that just so that that family doesn't have to move the loved one to a nursing home, they'll pay $15,000 a month for care and another $10,000, $12,000, $15,000 for a 24-hour non-medical caregiver, just so you don't have to go to that dreaded nursing home. So on the legal nurse consulting side, I see lots of lawsuits on the assisted living side because those people that are owning and managing the facilities are not setting limits. So when you go into an assisted living facility, what you want to ask is how sick can somebody be, and when do you do discharges? That's really, really important because the staffing mix and the people that are available to care for your loved one are very different than in a nursing home. So home-based care, it's a familiar place. It's home, okay? Even when we're really demented, we're able to find our way around. We're not going to bump into things and stub our toes, right? Usually have family availability, or at least friends or neighbors. I'll often see in a neighborhood, the neighborhood all aged. So everybody that was in the neighborhood moved in when they were young, in their 20s or 30s, and they've lived there for 50 or 60 years, and they're all aging together. And so young families are moving in. And sometimes the young families are there or not. The caregiver ratio. Usually have somebody in the house with mom or dad, right? A family member or a caregiver, so it's usually often one-on-one. And you can find customized solutions. So if mom doesn't want to change her clothes, you can let her run around in a robe all day long, right? Or if she doesn't want to wear an incontinent product, you can deal with that, right? So there is some autonomy and customization. The cons of being at home is isolation. Okay, we are social creatures. We need interaction with other people, and we miss that. Even if you come over once a week or twice a week or 3 times a week or have someone with your mom or dad, it's still very isolating. Adult daycares are a great way to get that senior. An adult daycare is kind of like a kid care setting where seniors go to interact with other seniors, to eat a meal, to have some activities. The home-based caregiver fatigue. You know, you're there 24/7, and often the families that I work with, whoever the caregiver is that's in the home, still is not sleeping because they're worried about what's happening. Okay, even though you've got somebody there helping you, we very seriously take this caregiving stuff. There's no clinical expertise, right? There's nobody really to see what's going on when there's a change and recognize it prospectively until maybe we're hospitalized. Behavior management, you know, the question we had this morning, what do you do when mom can't remember the name cup? You know, there's not a right or wrong answer. But if every time you can't remember cup, I challenge you, before long, you're going to get really angry with me and not even talk to me. And, you know, the executive function and those social boundaries are gone, okay? So I yell at people I care about. I do things that are not appropriate. Environmental safety, is your house able to be made safe, okay? You know, if you live in a tri-level or you know, in a home that has 4 floors, is it possible to put an elevator in? Do you want to put an elevator in? Is that an issue of decor and resale of the home? I mean, there are lots of issues along that. Finding reliable help. One of the people that I worked with, I had 21 different caregivers in her house over a year and a half. I interviewed every one of them, I trained them, I talked to them, I supervised them, but you're talking about non-medical people and who's supervising that person. And finding people that are adequately trained that understand. The people that are on the non-medical side, you know, the vast majority care, but again, they're not clinicians like I am.
Can I?
Sure.
One of the things also in today's society and workforce is that some of those help may be from other cultures, other races, other religions, or combination. And one of the things that I've seen, and I'm sure you have too, is it starts to evoke issues around who's coming into the home and whatever. People may have prejudices. They may have beliefs about who tends to steal from them. That one of the things about home-based care and the diversity that you run into with help is sometimes old beliefs or current beliefs about different things, and you can get not just personality clashes, but you can get really difficult things happening. So it's not an easy situation.
I actually have a home care agency, and before I ever bring one of my caregivers into the house, I ask the family, and the family is usually who hires me, does your mom care if somebody of color cares for her? And the families will just kind of look down and be really embarrassed and say, yeah, mom doesn't like it. Tell me, okay? Because if you don't tell me, what I'm going to do is it will be unsuccessful, because your mom is demented. She doesn't understand. She's going to say evil and mean things, but not because she's an evil, mean person. That's her belief system. And you know, we're talking about...
Let me say something about this home care and this issue here of getting adequate care in the home and get specialists. Aging in place is the golden rule, and you'll have lots of people say that. You're going to have to carry me out of this house feet first. Sometimes you do. The equation changes radically when that person gets dementia, because as we heard this morning, it's a progressive disease. Today is the best day because tomorrow's going to be worse. It's going to be going on from on here. And if you have significant dementia, it's possible to keep them in the home with enough care. You can do it, but it's cost a lot of money. But there are reasons there are assisted living units that have dementia, special dementia units. There are reasons you have nursing homes with special dementia units, is because you get, you can potentially get higher quality care. You get people who do that all the time. They're not a day laborer. You can potentially have better care for that demented person in an institution than at home. And the problem isn't the demented person, because they often don't even know where they are at some point. It's the family member who doesn't want to, at some point, it ceases to be, mom doesn't want to leave. It's, I don't want mom to leave because I don't want the guilt. But you're really doing no favor to mom, leaving her in a situation where you have 21 people come through. Even this is, the best you could hope. You got a top-notch person helping you, much less trying to do it on your own. And the other issue is, you should think about this. If you're so involved with the caregiving for a parent, because you're so involved with hiring people, supervising, on-hands care, when do you have time to be the loving child? You're so angry at the parent, you're so frustrated at the world you find yourself in, that you have a hostility to your parent rather than frustration. And you might find, if you can get your parent into an institution where there's the right institution, and you'll talk how to do that, you can then be the child again. You can be the loving child and not be their caregiver or care assessment or case manager and all that kind of things like that. So I really think we have to help. You have to think about in your own lives, am I better off being a case manager and running an employment agency, or am I better off being the person who brings a box of chocolates to mom and just laughs off her foibles because I'm not frustrated with those foibles? Someone I'm in that institution is dealing with mom's foibles.
That's a great point.
Even at home, people will say, well, why do we need you? Do you want to be the daughter and son again, or do you want to continue to be the caregiver? And it's your choice. Because I can take on those caregiving responsibilities, and I can build a system so they'll be safe, so that you can go out to dinner with mom, or you can get your hair cut with her, or go get your nails done. And it really helps us fulfill that child-parent relationship again. So institutional care, pros, socialization. Okay, you got clinical experience, just like Larry said. You've got people that have expertise. You have physician access and medication management. I think we've talked about medication about 3 or 4 times. Somebody overlooking that medication and make sure things are okay. On the con side, it's institutional. It doesn't matter how many times you say, oh, this is your home, this is where you live. It's an institutional setting. If it's neighborhoods, if it's person-centered care, it's not your home. The resident, though, that has dementia doesn't know it's where I live. I know you have a story.
I'll tell a little bit more. That my mother, who How many people remember Dr. Ruth Westheimer, the sex therapist, little teeny thing with the accent? That's like my mother. My mother is 101 years old. She's a Polish Jew, went through the Holocaust, and I realized how short she was one time when I opened the door for her like this and she walked under my arm. She recently went from independent living facility to dementia unit on a nursing home. And I was talking with her on Sunday, and I said, how are you doing on the unit, whatever? And she says, what do you mean the unit? And I said, well, you know, where you live. And she said, well, you know, I call it the place where I live. I mean, why do you call it the unit? And at that point, I realized, from now on, we're calling it the place where you live. Of course, she also says that in the evening, she goes to stay in Maria's apartment, and during the day, she stays in her apartment. Maria was her older sister, has been dead for 15 years. I said, where's Maria? She says, oh, she's in New York. So I'm living some of this thing.
And you know, the question before was, you know, well, how do we know what to do? If it doesn't work, don't do it again, okay? If pointing out that this is a cup doesn't work and it agitates the person, then don't do that anymore, okay? There aren't any magical answers, and that's when we're working with somebody with dementia. I'm not a parent, but I think that's what child rearing is too, isn't it? Every day is a new experience, and every kid's a new person, and so you try different strategies. It's the same thing, okay? There are some core things that we bring at 80 years old. One of the cons is customer service, okay? Healthcare has done a very poor job of understanding that we are customer service people. I went to culinary school about 15 years ago, and sitting in one of my culinary classes thought, oh my gosh, that's how people have been judging me for 20 years. Do I smile? Do I make eye contact? Do I have a name tag on? Do I respect you? Do I talk to you? Are the linens clean? Are there enough of them? Is the place clean? That's hospitality, isn't it? No one has ever asked me, Marty, do you know how to start an intercath or do a dressing on a central line or put in a catheter? You don't ask me that stuff. You assume I know that because I have RN after my name, right? So how do you judge me? In the way that you know how to judge me, right? Supervision, you know, I'll often have families tell me, well, mom's been falling, has had a lot of weight loss, has had all these things going on, and we're going to admit her to the nursing home so that doesn't happen anymore. This is a progressive disease. Mom's going to continue to deteriorate. If one-on-one you could not prevent her from falling, I can guarantee you that they're not going to prevent her from falling at the nursing home, okay? So some expectation kinds of things. And then there's always, we're in a congregate setting, so there's issue with infection. Another pearl, when you're going to that facility, make an appointment with them for the first visit. They deserve that, don't you think? They want to be on their best behavior. But don't make a decision based on that. Come back at other times. When you come back, come at mealtime. Come on the weekends, okay? The bosses are all gone on the weekends and at evening. And go to the dining room and watch what goes on. If 90% of the trays go back to the kitchen with most of the food on them, then I got a problem, right? If everybody's yelling and screaming at each other and this is not a good dining experience, then that's a place you want to reconsider, right? Asked to walk through the entire building, okay? When I walk through a building, I stop and I talk to residents, I stop and I talk to staff. How long have you lived here? They may be totally demented, but that's okay. I don't live here. I'm at work here. Oh, how's it like to work here? Well, it's okay, but the food stinks. You know, you just get all kinds of answers, but you take those as a trend as you're walking around the building. Stop and ask questions. You know, stop and ask staff. How long have you worked here? Why do you work here? Oh, this place stinks. We're always short-staffed and I hate it here. Well, you know, you listen to that and you hear what's going on and you're walking around the building with the person who's the representative of the organization. What are they going to say about that? Okay? So really, really probe. You know, there's something called Medicare Compare, which is part of the CMS, and it has this star, like hospitals have it too, with the star ratings. I don't know if you'd like your business managed or compared to other businesses, but that's done in about a 3 to 4 day stay once every 12 to 16 months. So is your business always on all cylinders when there are people in the building supervising you? If you've got auditors, if you've got managers, if you've got, and that's how those stars come up. And in fact, the CMS just is downgrading, I think it's about 40% of people that were 5 stars because they said they didn't deserve them. So that whole system is suspect. Very little inter-rater reliability. Then make some follow-up visits, weekends, evenings, but talk to people, okay? Don't make a decision based on who the person that's the marketer, because that's the person that's the admission coordinator is a marketer, right? Don't make a decision based on what that person says about the building. Question them, okay? And you know, when I question, I'm asking really clinical things about, you know, how many catheters and how many feeding tubes, and I actually ask how many employees do you have off on work-related injuries? What do you know about work-related injuries? Well, if they're off for work-related injuries, the first thing is you're not managing well. And secondly, if they're off, you probably didn't replace them. So I'm concerned about your staffing ratios, right? I've actually had nursing home administrators ask me to leave because nobody asks those questions, including the state. Well, you might guess that that's not a place that I suggest that any of my clients and patients go. Here's the Medicare. If we're monitored, if we're watched, our behavior changes, doesn't it? Okay, and so just a sense. Standard of care which is what I as a nurse am responsible for. So how do I care for a dementia patient, or how do I care for a patient with specific diagnosis? That's called standard of care. And standard of care isn't defined by regulators. It's defined by my professional organization. So when we're looking at that Medicare Compare, we're looking at a regulatory oversight body. Be patient with the staff at the facility. Now, you're impatient when you're taking care of that person at home, right? Sir? The Hawthorne effect is behavior changes if it's watched. And it does, okay? I either get nervous or it's like I always put gloves on, and when somebody's watching me, I do a dressing change without gloves. Duh, okay? So we know that if we're monitored, behaviors change. You know your loved one best. Tell us who they were, okay? I am exceedingly independent. Never married, no kids, live life on my own terms. When I'm a demented little 90-year-old lady, do you think I'm going to be any less independent? No. And you know what I'm going to do? I'm going to fall. And you're going to come in and you're going to say, Marty, you got to put the call light on. You got to tell me. And I'm going to look at you and I'm going to smile and I'm going to pat your hand and say, I know, Ryan, thanks for worrying about me. I'll do better, okay? And Ryan walks out of the room, and what am I going to do? Get up and fall down again, okay? That's who I am, right? So be advocates for your loved ones. Tell us who they are. Tell us who their core personalities are. Give us the information so that we can take care of them. Check in periodically, okay? Nursing homes have not a very good reputation, but I've been in facilities that families dump off loved ones and then never show up again. Please stay connected. Ask questions if you don't understand things. And tell us what your expectations are, because then I can talk you through what's realistic. So if you're admitting your mom because you don't ever want her to fall again, we need to have a dialogue about that, don't we? Okay? I can't guarantee that. You know, she's probably going to continue to fall, but these are the things we'll put in place. And so when you call me back, you'll say, okay, Marty, did you have these things in place? What else can you do? Okay? I need you to be my partner. I need you to work with me and to help me care for your loved one. I think I did okay. Questions, comments?
Well, I think I'd like to talk a little more about assisted living, and you can certainly correct me, because assisted living, as Marty pointed out, is highly regulated by states. It was originally kind of a term of art that care homes adopted, and now they have to meet certain state regulations. And the key is that they can't keep people beyond a certain level of medical condition, care need. There's a state standard. Every state would be a little different, but there's some point where the assisted living cannot, by law, continue to house that person because their health needs and care needs exceed the level that that assisted living is licensed to provide. And one of the quick and dirty cuts is you have to be ambulatory in almost all states. If you're totally bedridden, probably that assisted living, depending on state law, cannot keep you in assisted living anymore. Assisted living is really driving down the percentage of people in nursing homes. Nursing homes are getting sicker and older, the residents, because it turns out that a lot of people who were in nursing homes did not need that kind of skilled nursing care. They don't need a nurse down the hall. They need a lot of personal care, a lot of observation, a lot of help getting dressed, make sure you eat, make sure your medications are being properly attended to, which is a big thing. But they don't really need them. They're not having a medical condition. If the reason a family member needs to leave their home is dementia, your first place to look would be assisted living, and assisted living that have dementia care units. Is this problem of elopement, where people wander off. And so you need to have a wing or a floor where the people with dementia cannot get out of the facility. For example, one way is if there's an elevator that comes up, you need a key to get the elevator to go back down, so you can't leave the floor. That's a classic example. Or it can be a unit that's in a circle, so you can keep walking around all day, but you never leave the facility, as it were. So dementia is really treated until you get fairly deep into the dementia, get bedridden. You can do that in assisted living. And assisted living, they do specialize in, I call it the chandelier system. You walk in, there are lots of chandeliers in assisted living. And that goes to your point. That's to make the family think this is a really great place to be because there are a lot of, it looks nice. And this is the conversation you have. You walk in with mom, you say, gee, mom, you see the big chandelier. I think you're going to like it here. This is a nice place. Because, you know, well, mom's grumbling under her breath. I don't think so.
Mom says, don't look at the chandelier, look at the place.
But then you have to do what has been pointed out. You really have to investigate beyond the chandelier. So that's your first step with dementia. Now, on the other hand, if your older person has a medical problem beyond getting drugs, because one of the things assisted living does, they can't do, they're limited on the medications they can do, what they can do about medications, but they will monitor medications. They'll make sure that if mom is on 7 pills, she'll get the 7 pills every day in the right order. If you start having medical conditions, organ failure, other things, then you have to think about a nursing home because you're looking for the ability to provide a skilled nurse 24/7. And nursing homes tend to be much more institutionalized than assisted living. Again, you want to, I'm generalizing, obviously it varies. But assisted living, typically, you have to come down every day, 3 times a day, to the meal gathering place. What's the word?
Dining room.
Dining. It was a technical term, jargon, called dining room. Yes. Come down to the dining room. Other than that, in assisted living, if you're not demented or not so demented, you're pretty much, you come and go as you like. There's no, you're not locked in. Yeah, question?
I just wonder if each of you could speak to a place that you think does an amazing job as an assisted living place, as a nursing home,
Okay, well,
or
the question
as a service provider for in-home care. My mother is in New York. Doesn't
Okay.
matter, but just what you would look
in-house,
at. as a great
how do you find a top rate, it really comes to this question, how do you find a top rate in-home care entity, either person or agency?
We call them.
Because you want to go to an agency because you don't want to be hiring off the streets. You want an agency to vet these caregivers. You want the agency to worry about the 1099 form, the withholding on income tax. So you want to go to an agency. That's the first thing. Secondly, the best way, I would say, is talk to people who have parents who are a little further down the line than your parent and ask where did they go and were they happy? Is that?
Right. Actually, I can answer that really easily. My mom's in one. My mother is in Cleveland, Ohio, and this gets into some other interesting things we can talk about. She has been in she was in independent living, and then actually kind of skipped by pretty quick assisted living, but she's in the nursing home side. They do have dementia nurses. She's at a place In Beechwood, Ohio, it's called Menorah Park, and one of the important characteristics is places that have the full spectrum of care and can fund that in a really good, careful way, that every single step along the way on the independent living side is probably the best independent living facility I've ever seen. And I've worked in a lot and stuff, just like Marty has. The things that I saw that made my wife and me happy, the staff was incredibly caring. And not just smiling like Marty says about when he come visit, but in every single interaction we had, they were interested to hear what we had to say, they were thoughtful, they were not impulsive, they did what they promised, they followed through, they were reliable and responsive. I mean, what makes a great independent living facility or assisted living facility is what makes any business great. You know, do you deliver on what you promise consistently over time? They collaborated. Now, again, I'm a little different. You can imagine I'm a very knowledgeable on every level kind of a thing, so I was like such a partner to them that it was really helpful. But the idea of, I know that they would do that with anybody, including people who had no idea what they were doing. The facility was clean everywhere we went. The dining hall was well run with decent food. And I have to say, it's really hard to have a good dining hall in independent living, somewhat, but assisted living in a nursing home, because you have to manage salt and allergies and all sorts of things that people have and medication stuff. And we're a Jewish family. It's a kosher facility. So they had to keep kosher on everything that went on too. So what I saw was a level of diligence and consistency, professionalism. People stayed in their jobs for long periods of time. There was not turnover. These are the things that make, and when my mother moved to the nursing home side of Menorah Park last December, I saw the same level that we had seen in the prior areas. Does that help give you a picture of what you're looking for?
Well, it exactly describes where my mom was during rehab, but now she's home. And so it's, even though it's the same company that's delivering the home care, we feel much more stranded.
And, you
Well,
know,
if people couldn't hear, when her mother was in rehab, she got that kind of level, but now mother's home again, and they're providing home care, and you said you feel much more stranded?
Yeah, because mom is with one person who's a home health aide for 12 hours a day, and there have already been 4 people in 3 weeks, total turnover of the original, and we're not there to supervise, so it's just, that's what makes you feel worried.
ill at ease.
Marty, my mom is like you, she's independent, she's been hospitalized 4 times for a fall, and she already, you know, does all the contraindicated things, like not telling somebody when she wants to get up.
I
don't, so then, what do you do?
well, you know, they're asking, so what do you do?
Well, I got to summarize.
With-
The problem is, excuse me, is mom goes back home. She now has caregiver coming 12-hour days, but mother's has opinions. And as a result, they had some caregiver turnover. And the problem is, how are we going to get this situation stabilized where mom can get the degree of independence she wants, but we know she's getting the level of care she wants? How do we get this thing in balance?
What I do for families that live all over the country is, you know, the families will do the initial screen on some of the more hospitality things that you're comfortable with looking at, and then engage me for an hour-long call with the director of nurses at the facility and the administrator. And I'll tell you how a building is run. I've been doing consulting on a risk management side for decades, and I can tell you these guys know what they're doing, these guys don't know what they're doing. So just over the phone, I can help with that. A comment about the continuing care retirement community, which is what this gentleman was talking about. There is a kind of facility. So we have independent living, and then we have buildings that are independent where I can take care of myself, and there's also an assisted living component in that same building. Then there's freestanding nursing homes, and then there are things called CCRCs, continuing care retirement communities. Most continuing care retirement communities, there's an entrance fee. The entrance fee can be anywhere from, depending on the organization and what's going on, $150,000 to $1 million, okay? And they will provide lifetime care for you with that entrance fee. They market themselves, and there will be a contract that you'll sign. They do financial analysis to make sure that they're never ever going to have to pay for your services, that you have adequate resources to pay for them into perpetuity. And they also market themselves as you'll never have to move again. Well, if you have dementia, moving from building A, which is independent, to building B, which is assisted living, is as bad as moving from here to California.
Right.
So take that as it might be. You also pay a monthly fee. From a financial standpoint, I don't like CCRCs. I give you $500,000 of my money. You give me 90 or 85% of it at the end of tenure. I just lost 15% of my assets that I invested. Where else do I invest those kinds of assets and not expect any return? The world according to Marty.
Well,
okay?
actually, it's funny because I agree with Marty on that, and what Marty doesn't know that is another reason why I love the Place for Mothers. They did not require an entrance fee. That basically she came in and she paid something like $3,400 a month rent for her apartment in the independent living side, and that was it.
And there
So
are.
we had the best of all possible worlds.
So when you're looking at these places, the message.
I want to file a minority report here.
Okay,
All right.
and we want it.
Full disclosure, I was on the board of directors of the Central Corporation, the Kendall Corporation, which is a Quaker-affiliated entity that runs a series of CCRCs across the country, including one right here in Chicago called the Admiral. She's the chair of the board.
Okay.
Absolutely. I told you it was according to Marty. There's also a difference. There's
Yeah,
absolutely.
Okay, I'll continue with my minority report because we need some more facts on the table.
Okay.
Many of these CCRCs are religiously affiliated, not all. I would probably recommend those. You can pick your religion. You name a religion, they've got a CCRC.
Oh, yeah.
And obviously there are, but here's what the original model, and they've morphed into many models. You pay a large upfront fee, $300,000-$400,000. Then they guarantee that your monthly cost will not change despite the level of care required. So if you're paying $4,000 a month, it stays at $4,000 a month. Now, it may go up annually because cost of living. But if you move from independent living, where about all you're getting is, they change your sheets, keep the place clean, there's a nice common room and all that kind of stuff. You get one meal a day. Now you move into assisted living because your ability to care for, you can't cook very well, and your eyesight's bad. You're not eating very well. So they move you into assisted living. Maybe you got some dementia, maybe not. And now you're getting 3 meals a day and a lot more care. Still paying $4,000 a month. And then things really fall off the table. You have significant heart problems. You really have to be in bed. You can't get around. And they move you into a nursing unit, and you still pay $4,000 a month, even though if you were in actual nursing care, it would be maybe $7,000 or $8,000. Now, what that upfront fee was, it used to be non-refundable almost universally. It was actually prepaid healthcare, long-term care insurance. What you were doing was paying a large amount upfront, and if you needed extensive long-term care, you would essentially have prepaid it. Now, you might die lucky. You might stay in independent living forever and never move on, and then it would have been a bad deal, like all insurance. If you don't qualify for the benefits, it's a bad deal, but that's the essence of insurance.
It's like a one-time insurance premium.
Right, so, and in fact, the IRS recognizes this because part of that upfront cost is deductible as a medical expense under Section 213. They'll tell you when you move in what proportion of that's a deductible expense. Now, that has morphed into a different series of CCRCs. Many of them now have refundable fees because people love that. They don't like that bet. I'll put $300,000 if I don't live very long. That's a bad bet. So many of them have some percentage of refundability. Others have a scale where your monthly fee will go up if you go particularly into the nursing care. They usually keep it level through assisted living, but it'll jump up in the nursing care. So there are all sorts of places. These things, I mean, in a sense, all sorts of financial models that may or may not fit you. The reason it's a good deal, sure, if you're too demented, you don't know where you're moving, but for a couple, for example, you can have a couple move in, and then typically it's the husband, because he's a little older and sicker, has to move maybe into the nursing home care. The wife lives right down the hall, rather than trying to drive across town to see her husband. She's 85 years old. Secondly, someone's watching over that person. Unlike home care, you're in your independent living. You're living in a little apartment there. The Admiral here is a high-rise. Most of these tend to be low-rise units. Many of them have swimming pools. They're designed to appeal to the upper middle class and upper class. That's just very strictly, and so they are designed to have comforts of quality of living that it would appeal to those of us in this room. So they have putting greens, they have woodworking rooms. I send my students to see one that's a Presbyterian affiliated one. They come back and say, how soon can I move in? It's so much better than the way they're living. Now, so that is that's a possible model. You have to commit, though, while you're still healthy enough, because they won't take you unless you can move into independent living. That's where that's where you're a low-cost resident. But you move in, your health deteriorates a little bit, then they move you to assisted living, where you can get 3 meals a day, someone's watching out for you. Even if you're in independent living, if you don't show up for the evening meal, they come to your unit and try to find out what's happened to you. You'd be surprised how much comfort that is for a child to know that someone, if mom doesn't show up, someone will know it. The numbers who go into nursing care is relatively low because, again, they've got you in this assisted living with probably a higher ratio of employees to residents than you would have in a typical freestanding assisted living because they got the money. Well, you say no, I say yes. We can compare the numbers. But the percentage that go into nursing home care is lower than you might imagine because people tend to die off before they need that intense care. But if they need it, they go into the nursing care. And because, and here's the model, it's the real kicker, they have every reason to keep you in assisted living rather than the nursing home because it's so much cheaper for them to keep you in assisted living. So they tend to want to keep you as healthy as they keep you as long as possible in that level of care, and they'll move you eventually. The other thing you might get, depends on the unit, you might get a single room in the nursing home. You go into almost any freestanding nursing home in America, you will share a room because they're all designed to qualify for Medicare and Medicaid, and those government programs will only pay for a shared room. There aren't enough people out there who can afford to pay for their own room to build single-room nursing homes. But many, not all, CCRCs keep people in, or try to keep people in single-room nursing homes. It's a better world. I would say this. I think anybody who has substantial assets ought to consider a CCRC and then make your own judgment. It may not be the model for you, or you may say that's a wonderful model. But it depends on, and you may be comfortable with high prepay. You might say, like you do, it's not the model. I don't want to take that bet. And that's good. But that's just a minority report.
and the profit versus not for profit also makes a difference when you're out looking at organizations. The people that I work with, I show them all options. You know, it's not my money, it's not my choice. I'm really looking at quality of care. And you want to make sure that you have an attorney look at those contracts.
Right,
because
exactly.
I've seen time and time again where people signed a contract in one of these CCRCs and the family members moved in, were not comfortable with the model, which is appropriate, and could not move back out without substantial penalties.
Absolutely.
So, you know, there's no perfect answer. And it's just a matter of what you're comfortable with, but you know, do your due diligence on the front end. Your comment about the agencies coming in to take care of folks, is really pretty unregulated. In my company, if I get 100 applications for in-home caregivers, non-medical in-home caregivers, I'm lucky if I get 5 people at training. It's an amazing experience. And, you know, I think I do a good job. So no easy answers. It's really, there are kind of 3 models. There's, for the in-home care, there's the ladies that are immigrants that come and work, and you pay them, and you're responsible for their taxes, and if they get injured and those kinds of things. Then there are agencies that are franchises, and you see them advertised on TV. And then there are agencies like mine, the people that have franchises by zip code areas. And so if I'm working with agency ABC in this zip code and my next patient lives in this area, I can't use the people that have the agency in this zip code. I got to use somebody else, and I'm not as comfortable with them. My model is I can, wherever my license is, I can provide care to people, and the only people that I'm responsible for is me and my employees. So there are lots of different ways to provide care. None of them are the best, none of them are the worst. You know, we each have different opinions depending on what we're looking at. But you guys are in a position that you have the resources that you can kind of buy anything. And that's a wonderful place to be because everybody doesn't have that.
So one of the things I wanted to add, I'm from Altair. This is the certified financial planner talking about sort of some of the implications of having someone in the home, though. You need to make sure your insurance agent knows that because the last thing that you want to do is hire one of those ladies and then they get injured helping mom out of bed, or they fall because they're trying to help mom, and then you have a whole other issue. So you want to make sure that you have the right amount of personal liability umbrella insurance and those kinds of things too. So there's sort of another component piece that you need to be mindful of.
As your lawyer, I would say I would never advise people to hire directly. I would always go through Marty or an agency because of the liability issues and the tax issues. And it's and even if after I have them in the home through an agency, I'd still get an umbrella policy because you could still have liability issues. So whenever you bring a worker regularly into your home, right? Yep. You better be just go out, talk to your financial people, make sure you've got the umbrella insurance policies are not particularly expensive, but it's a great peace of mind. But I would strongly urge you not to go through Marty, not go on the street and hire people because.
You know, I have, yes, ma'am.
That we haven't touched on, whether it's at home health, at home care or in a retirement setting. And that psychological and the interaction with other people.
Absolutely.
How would you respond to that as you
The
look at this?
socialization is really, living at home is wonderful because it's home. The whole is the socialization. Adult daycares are great. Going out to dinner, going out with friends, going out to have your hair done, going out to get your nails done, just getting out around other people and other people that are not perhaps as debilitated as you are. I mean, I have some of my patients that are very demented, and we go out for meals, and we have the best time because they strike up conversations with everybody, and we're talking about, you know, him tramping across World War II, France in World War II, and you know, we just have these wonderful engaging conversations, you know, and I learn all kinds of things. So, point well taken. That socialization is so critical. That's really the big downside, and it actually, from a cognition standpoint, makes a big difference.
Here, I'm going to put in a slight minority report, maybe an alternative view. Some of it goes back to personality because what I have found in working with a variety of clients is a lot depends on whether the person has been an introvert or an extrovert. Because one of the things I found is for strongly introverted people, their privacy, their quiet time, people don't understand the nature of what makes an introvert versus an extrovert. It's not what you think about whether somebody is, has social skills or whatever. Introverts get recharged in your personal energy by being alone and having quiet time. Extroverts get personal energy and get recharged by interaction with people. That's actually the true definition of an introvert versus an extrovert. And so somebody who's been very independent but strongly introverted, likes their quiet time, has one cat at home or something like that, I've seen them really experience facilities as extremely stressful because they never have any privacy. And so I think you need
Absolutely.
to understand the individual, and going back to my mother, she's an example where she's putting up with it, but one of the things that is most precious to her is just to be able to get back to her room and have some quiet. She also, there's a risk of being able to seclude, depression and other sorts of things, so you have to have a balance. But generally, sociable, gregarious people benefit more from the socialization aspect of facilities than people who've been pretty introverted and inside.
And we're going to take a break at that so we can make our break at least 10 minutes long. If you have a question, if you could put it on top of your black folder so I can see it. The piece of paper can be folded over, but if you'd like a question read out, just put it there. Thank you.